This lecture talks about changes that occur within the mother during pregnancy. This is a great example of homeostasis, where we learn how all of the systems cooperate and compensate and contribute to the success of a pregnancy. Just a great illustration of this one physiological phenomenon that is homeostasis. So, you all have heard of morning sickness that's associated with pregnancy. A woman who probably may not even know that she's pregnant probably has started feeling nauseated, not interested in certain foods. And such changes can be due to increasing levels of certain hormones like estrogen and progesterone, and the presence of certain other hormones like human chorionic gonadotropin. Not all women would experience this, but most do. 2 out of 3 women go through what we call as morning sickness. And also note that this situation is not there throughout pregnancy. It starts off in the beginning and fades away by about 4 to 5 months of pregnancy. All right. Other mechanisms that we could add to this condition is that when you have a lot of progesterone, one key change to observe is that progesterone causes relaxation of the smooth muscle. So the lining of the digestive tract, where we have a lot of smooth muscle, will now be relaxed. So the movement of food, motility, is less than normal. So the food stays in the digestive tract longer. Some of the sphincters that open and close in response to certain cues may not respond as well. So those are the reasons for vomiting, nausea, and decreased appetite, etc. All right. With this, we will move on to another system that is affected. But another interesting thing before we leave this slide is to note that it's often more common when a woman is carrying a female fetus than a male fetus. This is true of the situation in 56% or so of pregnancies. Okay, so weight gain is natural during pregnancy. You already know that the fetus, the placenta, the amniotic fluid all contribute to the increase in weight. A woman during pregnancy also stores fat, especially in the breast area. And this is basically to use more energy that's needed during pregnancy. The growth of the fetus will be more dramatic in the 3rd trimester and not in the initial period of pregnancy. Okay, so another important thing to note here is the increased blood volume, increased overall fluid within the body, including interstitial fluid. So all of these elements, increased body fluids, increased storage of nutrients, and then the weight of the fetus, the placenta, the amniotic fluid, all contribute to this change. Metabolic activity also changes. You have to nourish the growing embryo, the fetus, and that means more energy is required. So if a normal healthy person uses approximately 2100 kilocalories per day. This varies from person to person based on the height and the weight and the activity, all of that. But if you assume that this is an average amount we use per day, a pregnant woman uses a little bit more, about 20% more energy than a non-pregnant person. Then even more interestingly, a woman who is nursing would require more energy, that is 3,000 kilocalories per day. So from 2,000 to 3,000, that is a significant jump. We tend to have more glucose in circulation during pregnancy. Why? Because glucose is the main nutrient and the one that can be used more readily by the fetus than other complex nutrients like lipids. So you expect more glucose to be in circulation. In order to allow more glucose in circulation, we may use sources of glucose such as glycogen, break it into glucose and see that there is enough glucose around. And hormones that are in the body in the larger amounts during pregnancy may also contribute to ensure that there is sufficient amount of glucose in the blood so that it is available for the fetus readily as and when needed. When it comes to protein, the body tends to spare proteins. So more buildup of protein. That's what you call as positive nitrogen balance. What we bring into the body is not all allowed to leave. So the nitrogen balance is off during pregnancy. More is kept in the body in the building process. All right. So you notice that approximately 500 grams of protein is retained. In other words, nitrogen or amino acid or protein, they're all from the same family. So you're talking about positive nitrogen balance. Urea is a major waste in the urine. And during pregnancy, the output of urea is reduced compared to non-pregnant situation. That explains that more nitrogenous products are retained in the body, and therefore less urea is produced, less nitrogenous waste is lost. All right. And additionally, some of the pregnancy hormones like human chorionic gonadotropin or HCG and placental growth hormone inhibit deamination. Deamination is where one amino acid, its nitrogen group is removed, and the rest of the structure could be plugged into glycolysis or Krebs cycle for energy purpose. So that is deamination, and during pregnancy, deamination is less because you do not want to use amino acids for energy purpose. Remember, this is an anabolic period, especially when it comes to protein synthesis, and that's where you need to reduce deamination and use these amino acids in the construction of new proteins. So there are numbers here. By the end of pregnancy, 500 grams have been retained, 50% in the fetus, 50% in the mother. Okay, so with this, let's move on to lipid metabolism. As I mentioned, there is more storage of fat during pregnancy. Most of it, happens to be within the breast tissue. Breasts do enlarge, and there is more adipose tissue added at that point. And the amount of fat circulating in the blood would also be higher than normal. Why? Because this fat is a source of it's a nutrient that is that could be used for energy purpose. And then a woman during pregnancy can become ketotic, meaning ketone bodies levels could be higher than normal, especially in a stressful condition such as during labor. Okay, the sympathetic activation or labor itself is a stressful condition. What happens is more fat is broken down and more ketone bodies are in circulation. All right. So with that, let's talk about body fluids and what all changes we expect to see in a pregnant woman. This is when there is a buildup of fluid, increased levels of fluid, chronic volume overload. Note that body water increases from 6.5 to 8.5 liters. That's a significant change, especially when there are so many mechanisms to regulate fluid volume in the body. You allow an increase of up to 2 liters at a term, including the fluid that's in the fetus, placenta, and the amniotic fluid. The gain is about 3.5 liters. All right, and what happens is there is increased sodium reabsorption at the kidney, but the amount of fluid is greater than the amount of sodium that's being reabsorbed. So there is typically less solute, less sodium than in a normal situation. That may make the body fluid concentration to be less than normal. In other words, the osmotic concentration of 300 milliosmol may not be the case in a pregnant situation. This time you look at changes that occur in terms of blood. Okay, blood volume increases. That includes the cells that are part of the blood. Red blood cell volume goes up 18 to about 25%. Okay, but note here the number of red blood cells, which is usually around 4.5 to 5 million per microliter of blood, here is dropped to 3.8 million. It doesn't make sense, right? When you say red blood cell number increases, but per microliter number has dropped, what does that make you think? Here, you notice that the volume of blood is the volume of fluid. There is so much fluid that even though there is an increase in red blood cells, per microliter concentration would be less. That's how you interpret this. So that's how a hematocrit would be lower. Hematocrit is actually the composition of cells in relation to plasma, blood cells versus plasma. So that would be reduced because plasma volume would be greater than the blood cell volume. And similarly, there is drop in hemoglobin concentration. This is all, again, there is more hemoglobin added because there is increased oxygen transportation during pregnancy. But please note that the volume increase does not match the increase in the cell or the protein numbers. Okay, so this is what you call as anemia of pregnancy. Okay, it's not really anemic condition, but it appears that way. All right, so now let's talk about leukocytes. These are white blood cells. Their numbers also have increased. Platelet numbers have increased, and their replacement is more frequent than normal. Increased plasma proteins, including fibrinogen. Fibrinogen is the protein that's involved in blood clotting. So what that means is a woman who is pregnant would be hypercoagulative. What that means is the tendency to clot blood is greater during pregnancy than during no pregnancy. All right. So that is what is mentioned here, increased clotting tendency. Plasma volume has increased 40 to 50% when blood cell increase is about 20% or so. So the mismatch is what is allowing us to notice anemic condition or decreased hemoglobin concentration or decreased red blood cell concentration. All right, now let's look at the systems and changes in various systems. A huge change in the cardiovascular system. Okay, remember there is an increased demand for oxygen, so there should be increased cardiac output. Yes, there is increased cardiac output. Okay, the increase is about 35% by 12 weeks, 50% increase by the end of pregnancy. And then during labor, it's much greater, 60 to 100%. And there are reasons for this that we will talk about later. All right, cardiac output highest right after delivery. Okay, that is due to autotransfusion. What that means is blood that was in the placenta is all released. Okay, because placenta begins to contract, and the blood that was in the placenta is all going to be kind of squeezed, and it contributes to the blood volume and the cardiac output. Okay, release of aortocaval compression. What happens is the position of the placenta, the position of the fetus would add some pressure on the blood vessels, like the aorta, abdominal aorta, and also inferior vena cava. So there is less blood moving through these vessels during late pregnancy, especially as the size of the fetus gets bigger. And when the baby is delivered, that pressure is gone. So there is that significant jump in the volume. All right. Increased heart rate, increased stroke volume. Stroke volume is the amount of blood that's ejected per heartbeat. Okay. That added up for 1 minute is what you call as cardiac output, and increased stroke volume automatically leads to increased cardiac output. Now, cardiac hypertrophy. Hypertrophy is the enlargement of the heart. Note that it is reversible because you're handling a large volume of blood. That is more blood arriving in the heart, more blood being ejected. There is some enlargement of the heart temporarily, and that could lead to conduction changes. Conduction changes are electrical changes that occur in the heart. They would all be slightly different than normal because of the change in the size and the behavior of the heart in increasing cardiac output and all of that. All right, changes in blood vessels as well. Blood pressure change typically is less than normal. Okay, typically less than normal. Okay, this may have some ups and downs in the different stages of pregnancy, but overall, the way to think is lower blood pressure than normal. The main cause for this is the smooth muscle relaxation that is lining the blood vessel wall. Okay, so the blood vessels are dilated, less peripheral resistance. Okay, lesser the resistance in the blood vessel, lesser the blood pressure, which you will learn eventually when we talk about the cardiovascular physiology. And also there is less viscosity of blood. Why? Because there is increased blood volume. Remember, plasma plasma levels have increased 40 to 50% during pregnancy. Then because of this low pressure, blood may not be returned as efficiently. What that means is stasis in legs. Okay, blood returning back to the heart from the legs can be an issue during pregnancy. Why? Blood has to move against gravity, and now the blood vessels are dilated and blood tends to stay back in the veins, and that leads to conditions like deep vein thrombosis. So someone with during pregnancy should keep an eye on conditions like deep vein thrombosis. And varicose veins could also develop during this time because of the blood staying back in the veins, in the legs especially, causing damage to those veins and varicose veins. Let's switch to respiratory changes that you expect during pregnancy. Well, anatomically, you would see the engorgement of the capillaries and mucosal lining, edematous retinoids. The retinoids are cartilages that line the larynx, so that could also be enlarged or swollen, and the vocal cords the same. So that is where the intubation and stuff has to be adjusted accordingly. Now, looking at the volumes and capacities, some of these terms may not be familiar to you, will be introduced to you at a later time. That's where you may have to wait until we have covered this in detail elsewhere. But in general, tidal volume is greater than normal. What is tidal volume? The amount of air that moves in or out of the lungs in one breath. Well, let's look at the abdominal situation. There is a fetus that's occupying this space, and then that means there is increased abdominal pressure. And also the space being taken, the diaphragm may not be able to shift lower as in a normal situation. So the use of diaphragm, especially in later part of pregnancy for breathing, is less. So it's basically the intercostal muscles that are used for breathing purpose. So you have to compensate here, and the signals that are generated would make the respiratory centers in the brain increase the intake of air. So more volume of air moves in or out. Okay, increased movement of the diaphragm and the flaring of ribs, increased tidal volume. And also, again, the action of the muscles is different now than before. You know why? Because of the progesterone, and the ability to expand and relax is all greater now than in that non-pregnant situation. So initially, yes, diaphragm can move more readily, but later less. So this is where you have to look at the different terms, different trimesters, and then adjust these volumes accordingly. When there is increased tidal volume, there is increased minute volume. Minute volume is the volume of air that moves in or out of the lungs in 1 minute. Okay, increased oxygen intake through the increased volume of air, and increased arterial oxygen, that is through the increased amount of hemoglobin, increased number of red blood cells, and increased oxygen supply to fetus. That is the goal overall, isn't it? We need to make sure that the fetus receives a surplus amount of oxygen. and increased expiration of air, that is the amount of air released is greater. That's again tidal volume being greater. Increased carbon dioxide output. Okay, so CO2 is lost in greater amounts than normal. What that could lead to is slight alkalosis. Because you're losing carbon dioxide, you're also losing the ability to generate hydrogen ions. Okay, so the blood pH may become slightly alkaline. Okay, so that is one reason for slight alkalosis in pregnant women. Decreased maternal blood CO2 because of the loss of increased amount of CO2. Decreased functional residual capacity. What that is the amount of air that remains in the lungs at the end of expiration is going to be reduced. It's like a reserve in the lungs. Typically, there is a certain amount, although we do not want to talk about all these numbers right away and wait till respiratory lecture, we can say that approximately about 1200 milliliter residual volume at the end of normal expiration, but here it's going to be less. Why? Because of the ability of the muscles to stretch and relax, etc. There is less of this retention of air, and decreased expiratory reserve volume by 20%. That is, at the end of maximum expiration, there is still a less air left in the lungs. That is lost by 20%. No change in vital capacity. This is going to be the forced expiratory volume in 1 minute is what you're talking about. The ratio of these two. These terms are too much for you to deal with right away, so we could talk about this later on. Let me hide this here so you can read this. You can see this, sorry. So let me take you back to this slide here. All right, so with that, let's move on to talk about this table here, simply summarizing all of these details nicely around the near term. Okay, so tidal volume increased, minute ventilation, breathing frequency is increased. You breathe more times than in a non-pregnant situation. Why? Because you're only using the intercostals and not the diaphragm as much. And then we talked about these lung volumes, and that can be a little too much for you to understand right now. Blood gases we talked about is where you talk about less CO2 than normal. So pH is either slightly alkaline or no change. Oxygen consumption has increased by 20%. All right, so this is where you can talk about lung volumes and changes and then the implication. Okay, this is important, especially for the medical professionals dealing with patients, especially during surgery. The functional residual capacity being reduced to 80% of non-pregnant value by term, meaning less reserve of air. And this functional residual capacity of pregnant women in a supine position, in a stand-up position, is 70% of that in a sitting position. Okay, so that is, position also affects the amount of air that's present in the lungs, and there is 70% compared to sitting position. So that is less in that position. Regional anesthesia further decreases the FRC. So that is important for you to keep in mind. Hence, supine pregnant patient with a regional block has a triply diminished FRC. So it's important detail to keep in mind. obesity is like another factor to contribute to lower FRC. So anesthetic implication is where very rapid desaturation in pregnant patients after apnea due to rapid sequence induction or a seizure. So this will be discussed later on in clinical courses for you, but this is just something to expect in pregnant women, especially if you have to prepare these patients for surgical procedures. All right, dyspnea of pregnancy, that is difficulty breathing. That is, remember, it is the less position, less abdominal space, the diaphragm not being able to move as far. It is just the intercostal muscles. And that is why it's more during later on in the late first trimester or early second trimester is where it's more than during the third trimester. You know why? Because then the position has shifted right below the upper abdominal space, and that's when things can get a little better in terms of dyspnea. Let's focus on the kidneys and the other structures and how they are affected during pregnancy. Okay, blood moves in greater amounts. Remember, there is vasodilation because of the smooth muscle relaxation. More blood reaches kidneys during pregnancy. That means increased glomerular filtration rate. GFR stands for glomerular filtration rate. It is greater than normal. All right. Now, that's one important change. Then note that creatinine levels are lower than normal. Okay, this is natural. Okay, why? Because you have more fluid to deal with, that automatically, changes the ratio. So less, it appears to be less creatinine than normal. You see, it's like you talking about less red blood cell number or less hemoglobin concentration. Although the numbers have increased, the increase in the volume would make you think that there is decreased number of red blood cells or decreased number of hemoglobin. And same is true with creatinine. All right. So normal creatinine would be considered abnormal here. All right. Frequency of micturition, that is releasing of urine or urination, is a common situation in pregnancy. Why? The pressure of the fetus on the bladder is the reason for increased micturition. Frequency of micturition is higher. The bladder may have the increased capacity to hold more urine, again because smooth muscle relaxation allows the expansion of the bladder more. But on the other hand, the position of the fetus, the pressure on the bladder may make it carry less urine than normal. So that's something that cancels one another. All right. Loss of tone of smooth muscle affects the ureters. The ureters are wider than normal, so they dilate. Okay, urine stagnation is something to keep in mind because of the dilation of the bladder, dilation of the ureter. Urine may sit there longer. And that leads to a new complication, that is infection. Okay, infection is often common because of stagnation of urine in these structures. Incomplete emptying is another reason for that. So ureteral obstruction with hydronephrosis and pyelonephritis is common. Obstruction is, again, the bladder or the ureter being relaxed and dilated, is where the obstruction with urine is common. Okay, 1 in 200 pregnancies will have urolithiasis. What this is the salts of salts of calcium, crystals of calcium. In other words, kidney stones could be deposited in places like the ureter, kidney, bladder, etc. All right, sodium loss during pregnancy, natriuresis. That is more sodium is lost during pregnancy due to the action of progesterone. On the other hand, note that there is renal tubular reabsorption of sodium that's greater in a pregnancy than at other times. Why? There are several hormones. Aldosterone is a big one, estrogen and deoxycorticosterone. These are those hormones that increase the reabsorption of sodium ion. So one compensates the other. Increased glucose excretion. Why? There is so much fluid being filtered. The amount of glucose that you find in the filtrate is going to be greater than normal, and glucose is reabsorbed using facilitated diffusion and the co-transport mechanisms. And now what happens is those carrier proteins are saturated with glucose, and now some may leave the system, and that could be the way to explain the loss of glucose in urine. 50% increase in the glomerular filtration rate. That means greater amount of glucose seen in the filtrate, and that is how you may not be able to claim all of the glucose and some loss of glucose. And similarly, loss of folate and other vitamins such as vitamin B12. Hormonal changes, we have already talked about this in the previous video, and let's talk about additional details. Fetus primarily depends on glucose. We learned that earlier that glucose is in circulation in greater amounts than during non-pregnancy, again because the fetus depends mainly on glucose in the blood supply. Active transport of amino acids to the fetus occurs. Ketones can also cross the placenta. A diabetogenic, that is the higher level of glucose than normal, may make a condition such as diabetes. This is a temporary situation in a pregnancy because of the increased amount of glucose, and there are a number of hormones that promote this. That is placental lactogen, the human growth hormone, cortisol, and progesterone all promote the presence of more glucose in the blood than in non-pregnant situations. Insulin requirement increases during pregnancy. Again, because you have more glucose, there is more nutrient intake and more nutrients in circulation. That's how you would increase the output of insulin. Renin-angiotensin-aldosterone system activated influences cardiac hypertrophy, increased red blood cell mass, and increased reabsorption of sodium, increased aldosterone, all of that. Let's now talk about the digestive system changes during pregnancy. We have looked at some of the changes already, that is how smooth muscle relaxation leads to the retention of food for a longer period of time than normal. Okay, that is decreased tone, decreased motility, and increased absorption. Okay, this is all progesterone mediated. Decreased tone of the gastroesophageal junction sphincter. Okay, that's the one that could lead to acid reflux. Very common during pregnancy, this condition, acid reflux. That is because of the poor sphincter function. This sphincter lower esophageal sphincter is another way to call this, may not close well, and there is that regurgitation of gastric content, and that's how there is acid reflux. Constipation is another common situation during pregnancy. Okay, one is this position of the fetus, and that could obstruct the intestines, and then decreased motility, increased water absorption because food stays longer in the digestive tract. All right, biliary cholesterol saturation increases, that is increased absorption of cholesterol, increased risk for gallstone formation because of this reason. We will talk about some of these details more in the digestive system discussion as well. All right, some changes in the skin to make a note of hyperpigmentation. Okay, skin color could be darker, especially in some areas. Areolar part of the breast would appear darker than normal. Okay, angiomata, spider stretch mark is what we call this, basically in the face, upper chest, or palmar erythema. Again, these red lines that run through the skin, those are all mediated by estrogen. Blood vessel arrangement and the appearance is all estrogen mediated. This is striae gravidarum. This is stretch mark, increased eccrine, sweating, and sebum excretion. All of those would be greater during pregnancy than normal. Okay, eccrine sweating is one type of a sweat, the thicker, smellier sweat. And sebum is oil. So the texture of the skin, the hair, can all be oily than during non-pregnancy. It also affects the bones and the muscle. The spine position changes. Lordosis is where the lumbar curvature is greater than normal, again to bear the additional weight of the fetus, especially during the third trimester. That may lead to back pain as well. Relaxin is a hormone that's made by the placenta that relaxes the pubic symphysis. This is a good thing. That is the way the body prepares itself for a labor. Okay, sacroiliac joints are also relaxed. Okay, facilitates vaginal delivery, but may lead to discomfort during pregnancy. And then other implications from this is unsteadiness of gait and trauma from falls during pregnancy. Now let's talk about calcium ion levels and other details associated with the skeletal system. Total serum calcium level declines throughout pregnancy. Well, how do we justify this? Is it the blood volume change that makes the calcium level decline? Yes, some of it is that. There you go. And then due to the fall in serum albumin, so the bound calcium would be decreased because of the decrease in serum albumin, who acts as a carrier for calcium ion. Ionized calcium is constant and unchanged. Okay, and this is the one that we often use in the nerve conduction or the muscle contraction, etc. A physiologic hyperparathyroidism. What's going on here? Because there is increased absorption of nutrients, decreased renal losses, there is more hyperparathyroid more parathyroid hormone secreted. Okay, no bone loss seen in bone density studies. Rate of bone turnover and remodeling is higher in pregnancy, twice as great at term. Okay, good. So other signs and symptoms to think about here is decreased exercise tolerance. You know about the changes that occur with the need for energy, and then the respiratory and the cardiovascular changes. All of that makes a woman be less tolerant to exercise, and dyspnea is difficulty breathing. Peripheral edema, the fluid volume being increased, and also less fluid returning back to the heart because of the retention of fluid in the veins, especially in the legs, could lead to peripheral edema. Distended neck veins, jugular vein here, could be wider than normal. Point of maximal impulse displaced to the left. So if you were to listen to the sounds of the heart, that may have shifted. Remember, the hypertrophy of the heart could be the cause for this. All right, so now we will talk about changes during pregnancy at term. Okay, close to the time of delivery, what all changes do you expect? Increased oxygen consumption, up to about 40 to 50% cardiac output by 50%. This is where we talk about autotransfusion again. This is during labor, contraction of the placenta, release of the blood back into the system. Functional residual capacity, we talked about that, decreases by 20%. Pregnant patient has diminished capacity to tolerate apnea. Apnea is a cessation of breathing, and that would not be easy for a pregnant woman. All right, now let's talk about autotransfusion. We have heard about this a few times now. So this is the displacement of blood from the contracting uterus. The blood is returning back into circulation during labor. Okay, first stage of labor is where the output would be about 20%. Second stage of labor is where it is even more, about 50%. And just after delivery of the placenta, the output is about 80% compared to pre-labor levels. Returns to pre-labor levels in 48 hours or so, and pre-pregnancy levels in about 12 to 24 weeks. All right, so with this, we can stop here and talk about parturition in the next video. Thank you.